part of the question, I said I wanted to talk a little bit about heart failure. So that's what we're going to do. So heart failure, first of all, is just simply your heart is not meeting the demands being placed on it. So it's not supplying adequate blood flow. So this is more commonly going to involve the left ventricle, as this is the ventricle that pumps blood out to your aorta and systemic circulation, which is more so where the issue stems from when you have those symptoms, because your whole body and your organs aren't receiving adequate blood supply. So, more common in left ventricle. It can involve the right ventricle. That's more of a secondary mechanism typically, though. If you have something go wrong with the pulmonic failure, that's typically when you start recruiting the right ventricle, because your pulmonic or your right ventricle is going to be responsible for sending blood to the lungs to get oxygenated. So that's kind of what we more associate that with. But there's two types of heart failure. The most common causes of both types are coronary artery disease, where we get buildup of soft atherosclerosis and the coronary arteries, and also myocardial infarctions, so your heart attacks. So there's two types, like I just mentioned. We have something called systolic failure and diastolic failure. So in systolic failure, we more oftenly call it HFrEF, so heart failure with reduced ejection fraction. This is the more serious kind. When we say reduced, we mean greater than 50% reduced. And what happens here is interrupted excitation-contraction coupling. So what I just talked about up here with this system, this becomes interrupted, not functioning properly. So what does this translate to? This translates to decreased contractility and ultimately decreased inotropy. And so if our heart has decreased inotropy, we have decreased cardiac output, because inotropy directly is a factor of stroke volume. And so our heart is not going to be able to pump as much blood out, therefore it's going to have to work harder, and we're going to have reduced exercise capacity because stroke volume. So here's our formula for cardiac output. It's going to be affected by preload, contractility, which we are directly taking a hit on here, and afterload, which is going to be the back pressure pushing on the aorta. So what this does, again, it interrupts our excitation-contraction coupling. So it's interrupting our depolarizations, which is the whole thing that I just talked about in the first part of this video. But what this directly disrupts is a mechanism called our Frank-Starling mechanism. I'm going to draw that out for you. It's kind of a bell curve. So the idea, simply put, with Frank-Starling is the greater the stretch, the greater the squeeze. Meaning, the further we stretch our ventricles, the further blood is going to be pushed out. And that's because of our sarcomeres. So our heart has sarcomeres, which we talked about briefly up here. These guys are bound within sarcomeres, which are kind of our smallest units of muscular contraction. So from Z disc to Z disc is a sarcomere. And in Frank-Starling, the idea being, depending on where our actin, so I'm going to draw actin in blue, and myosin are interacting, we can actually have a maximal, a most optimal point to where we're getting the greatest force. And it's kind of almost a physics-based idea, because if you think about it this way, if we're interacting from here, we are too far spread apart. These guys can't grab onto the myosin, and so we're not going to get an optimal contraction. If we're too close, say here, the only room we have to pull is right here. And this is kind of where we're generating our power and our force, which we want, because then we're ejecting more blood. We have more blood perfusing our organs. We have greater exercise capacity. So this is an ideal, but there is an ideal range where we're saying if we stretch to where we're just barely overlapping, but we still are, we get the maximum capacity to contract and then therefore eject blood. So right from this distance, we're getting that much more power. And the more blood we can eject, again, the more blood we can send out through systemic circulation, the greater we're perfusing our organs, the greater exercise capacity we have. But what this does when we have decreased contractility and decreased inotropy is actually puts a downward shift in this mechanism. So we're getting reduced ejection fraction because we're actually ejecting less blood out of the ventricles via this mechanism. So we do compensate because as we decrease this, we're going to get decreased stroke volume. So we see a compensatory increase in preload, right? Because we're decreasing contractility directly. So we try and compensate by preload. And so what we actually try and do is maximize our Frank-Starling mechanism. So we may actually try to get to this inefficient to stretch and stretch and stretch because our body is in a state kind of panic of saying, how are we going to handle this situation with decreased electrical input? So we kind of try and stretch to a maximal length, but it's not effective. And sometimes actually when it's so progressed, that systolic failure, we'll actually add on sarcomeres, but not in an efficient manner. We'll add them to where we don't have any greater contractile force, we're just dilating. So it's not uncommon to see in people who've had long-term or really severe systolic failure dilation of the left ventricles because the heart will start to compensate by actually adding on these sarcomeres, which is not a good thing. Again, this is not a productive, not the Frank-Starling where we're maximizing. We are dilating and coming towards this end of the spectrum with that. So that is not ideal. Either end of the bell curve is not ideal. It's kind of a statistical concept, but a pretty intuitive one. So the second type is called HFpEF. It is not as severe, obviously not ideal. It's preserved ejection fraction, so we still have greater than 50% ejection fraction from the ventricles. And what this guy is more often caused by is decreased compliance in the ventricles. So our ventricles just aren't as stretchy, so to speak. And this again kind of interrupts Frank-Starling because if they can't stretch as much, how are we going to get to that maximal force-producing interaction? And causes of this can be things like hypertrophic cardiomyopathy, decreased compliance just in general, impaired lusitropy. So impaired lusitropy, your lusitropy is your relaxation of your ventricles. And that seems kind of anti-intuitive at first, that a more relaxed ventricle is better. But what that means is a ventricle that is able to stretch. So again, if your ventricle cannot stretch, you cannot fill with as much blood, you cannot eject as much blood into the systemic circulation. A ventricle, cannot stretch to maximal amount. And so in diastolic failure, because diastolic we're talking about relaxation and systolic we're talking about active, we're talking about the actual contraction. So that's where those names come from. With this, we're obviously going to increase exercise tolerance because we're decreasing our cardiac output, because we're decreasing our stroke volume, which again, so we see decreased exercise tolerance, but for more reasons than just that, when we have this, so we activate our sympathetic system because we get decreased cardiac output. This is heart failure. That's the issue. Arterial pressure. So we kind of try and compensate. One of the things we do with our sympathetic system is activate things like renin, angiotensin. So we're storing more sodium and water inside of the body in order to increase blood pressure. But what we do is actually accumulate too much fluid. So we get things called edema, which is just excess fluid. So this is one major issue with heart failure is edema. So pulmonary and systemic edema. Pulmonary meaning in the lung, systemic in just the rest of your body's system. So oftentimes patients have to take medications to manage this. But this does cause an increase in cardiac output, which is positive, but one thing that's causing a decrease in cardiac output, when we activate our sympathetic system, our epinephrine or norepinephrine, we're actually causing vasoconstriction all across the body. And when we constrict down, we're increasing systemic vascular resistance, which is going to decrease our cardiac output. So although we're able to increase our arterial pressure and we're able to kind of compensate with our cardiac output on this side of things, with this guy, we're decreasing our cardiac output. So not only do we have decreased cardiac output, we have this accumulation of fluid. So we're kind of in this vicious cycle of one mechanism causes another harmful mechanism causes another. So you get into kind of a decompensatory cycle that's very dangerous. So again, we take medications to manage this. we take medications, commonly we take diuretics, because we need to get rid of some of this volume. So if we can pee out some of this volume, which that's what's going to happen, right? We're going to store less sodium. If we store less sodium, we're going to excrete more water. So pee blood volume out. This will help with the issue of edema. But we also then have this issue of our increased systemic vascular resistance. So we have to take vasodilators sometimes to help deal with that constriction that we've caused all across the body. So those are two common medications that we see. Our main goals when we're dealing with this is reducing edema and chest pain, right? Which is what we talked about, that mechanism that kind of causes that. Chest pain, because you're getting a lack of oxygen, you're getting ischemia, so you're going to have pain as tissue does not have sufficient oxygen to function. That's painful for our system. We want to increase cardiovascular function in order to increase organ perfusion, because our heart's not getting sufficient oxygen, our organs are not getting sufficient oxygen, they can't function at their optimal level, which is obviously not ideal. So that's one of our goals with medication. And there are different medications you could use to do so. You could use maybe a calcium channel blocker, again, the diuretics, you could use a vasodilator. So there's a variety of medications that a cardiologist may prescribe to these patients. And obviously, and most importantly, with any issue of human, whatever, animal medicine, is reduced mortality. We want increased survival rates. And these can get really serious, especially when we're talking about, again, something like HFrEF, where we're losing greater than 50% of our ejection fraction. And when I say ejection fraction, that's kind of synonymous with cardiac output. It's just more quantitative. It's the amount of blood we are actually ejecting from lungs. And it can often be used kind of as a for the heart. So we talked about kind of what's going on with this heart failure, some of the medical interventions. How can we actually see that, though? So we have different imaging modalities. The first one that comes to mind is called an echocardiogram. And an echocardiogram is actually, if I can spell echo, a form of an ultrasound. So how ultrasounds work is through sound waves, and actually kind of similarly to how bats hunt, which is called echolocation. So you have a transducer which sends out sound waves, and in the instance of looking at ejection fraction, which is what we're concerned about here, these sound waves will go out through the heart. So this is the heart. And depending on how it hits the blood, signals will either travel away from or towards the transducer. And that will give us kind of an image of what the blood volume is doing in the heart. And that's kind of the heart and going out of the heart, which is kind of what we're concerned with ejection fraction. So it gives us blood volume, which is a major key here when we're worried about, again, ejection fraction. And this is how an ultrasound works, even if you did an abdominal, but this just gives us more of the blood volume of the heart rather than, say, fluid from a cyst in the pelvis. Another thing we can do is a CMR, which this is an MRI, but of the heart. So how these technologies work is they're magnetic resonance imaging. And what we do is things have poles. So positive poles have kind of assigned order. When you put them in an MRI. Regularly, things are going to be oriented in all different sorts of directions, but when you put a person, because we're the sample in an MRI, it's a giant magnet, so all our poles will orient in one direction. And what we do then is we take radio frequencies and hit and interrupt. And these are the sounds you hear when you're in an MRI, that make you think you're going to go deaf. It's radio frequencies. And what they do is disrupt these signals and send them in all different directions. And then after those signals the radio frequencies have been released, we have a return to spin. And what the MRI is actually measuring is your return to spin, because different masses of things, different tissues will have different returns to spin outside of, say, a normal spin that can reveal what's going on. And so this is how we use a CMR. And it actually, in an MRI, it's photographs, say, of your knee, because your knee's not actively moving. But in a CMR, because your heart has to actively be contracting for you to be living, unless we were really making a production of, which is not the case for this. It's a video, so you can actually see the heart contracting as you're observing this and getting this image. So it's a really cool technique. It's by no means the standard, but it is interesting. And then we have something called a PET scan. This is nuclear imaging, so there are some associated risks with this, whereas an MRI, not so much. It's a magnet. An ultrasound, not so much. There is a risk with the PET scan. So it's positron emission tomography. And what's happening is it looks similar to an MRI, but you have someone inject something, typically like a radioactive glucose sample. And you have something called scintillation cameras. And so the person would enter, say, here. As radioactivity is detected, cameras that are 180 degrees apart will snap a photo at that point when something is directly equidistant between them. And that's how we get our image. So for a PET scan, it's typically overlaid with an MRI or a CT scan because there is no anatomy shown. You just get that radioactive photo. So it's common to combine with MRI or a CT scan. But it gives you this image to show radioactive activity, and this is particularly useful for, say, metabolism, cardiac function, because as tissues consume that radioactive glucose, you're having decay, and that decay can be measured by these scintillation cameras. So it allows you to see perfusion in the heart, which again is particularly useful for ejection fraction. Then finally, you have something called a CT calcium score, which this has less to do with actual ejection fraction and more just with heart function, but it's worth mentioning. It gives you a score for hard atherosclerosis. You want your score to be 0, but it can range between 0 to 400, lower the better. And it's kind of different in these guys in that it doesn't give you an image, or I scroll too far, like an ultrasound, a PET scan, an MRI, that just gives you a score. A regular CT scan can give you more information, but when we're talking specifically about this hard calcium score, which is common for the heart, this is what we're concerned about. Soft atherosclerosis is different than hard. Soft atherosclerosis is more what you think of with your foam cells and the accumulation in coronary artery disease. Can be equally, if not more, damaging. So just because it's soft doesn't mean it's better. So foam cell accumulation. But you do have two different types, and this only gives you a score for hard. Sorry, I can't write and type. Accumulation. Atherosclerosis. So this is kind of just an overview, a lot to do with depolarization and the function of the heart. I hope this was an informative video and gave you some insight onto cardiovascular physiology.